Good morning, all. Very glad to be with you today. I'm Matthew Donahue, internal medicine physician and acting state epidemiologist for Nebraska. I was part of CDC's Epidemic Intelligence Service when COVID 19 arrived, and I worked through multiple phases of the pandemic nationally and throughout Nebraska to develop and support public health interventions. It frequently felt like we were building the plane as we were flying it, and in some ways it still does. I'm going to walk you through some of the key phases of the pandemic, from the origins of the pandemic to the virus itself, to interventions we've used to counter it, to the consequences of the pandemic, a view of leadership and the role of censorship, and what the future might look like. I'm going to try to explain the path we've been on that got us here and explain some of what we've learned. Mostly, I want to highlight what I think we all need to think about moving forward. So here we are in 2019, sitting pretty good, looking pretty good. This was the Global Health Security Index built by Johns Hopkins. We evaluated different countries' capacity to respond to emerging public health threats. We ranked ourselves number one in the world for pandemic preparedness. That's the reputation. At least that's where we ranked ourselves. I saw it and I was even a little reassured by it. But I still worried a little. The consensus wasn't in, and from everything I'd studied and learned, the world was still producing new epidemics at a faster and faster pace. HIV, Ebola, Zika. Take it back 1 year before that 2019 report, and in 2018, The Atlantic did this piece that I remembered. This included UNMC's biocontainment unit, Dr. Fauci, several other leaders, and this ended in a less than hopeful tone. So with what we know now, does our record match our reputation? At times, we saw more than 4,000 deaths per day, and more than 700,000 Americans have died. I agree with The Atlantic here. COVID-19 called America's bluff. But what could we have prevented? What could have been different? I don't know. COVID-19 washed over the world, but from fragmented data systems to disparate state responses causing confusion across borders, to censorship and misinformation, we do have targets for improvement. And that's the first overarching question. How do we ensure the record aligns with the reputation? How can we do this better? I don't have all the answers, but I do have a starting point. We have to start with reflection, an understanding of what happened and how it happened, where we got stuck, and where we didn't. It's easy to move to the next case, move to the next patient, get by and survive, but unless we review and reflect, we won't learn. And if we don't learn, we won't get better. And I think we can get better. Let's talk about the beginning. I recall hearing whispers of a curious pneumonia in Wuhan in December. I snapped this headline in December and recall thinking, I wonder if this is history unfolding. It spread. It was isolated and it was sequenced. We learned it was a coronavirus. But that was about all we knew. We had experience in the past with garden variety coronaviruses that caused the common cold, and also had experience with another highly lethal epidemic coronavirus, which was the first SARS-CoV-1. It was contained through case investigations and contact tracing, and really, in the beginning, we didn't know where this was going to fall on the spectrum, whether it would be more like cold viruses or more like SARS. It kept spreading, and deaths began mounting, and we began worrying more. Soon, the media and Americans began realizing this virus might come here. In a push to contain the virus, Wuhan locked down hard, but not everyone who was there stayed there. Visitors returned to their home countries. Business associates flew back home. They purchased a boarding pass, and they jumped on a flight. It looked inevitable. It was coming. Prior to COVID's arrival in the US, I'd been deployed to LAX airport to begin symptom screening for flights coming from Wuhan. We set up the screening system, took temperatures, would run from terminal to terminal to screen the next flight, but it felt like only a matter of time. And then it happened. A person had tested positive. It was in Washington, and it arrived before screening had even begun. But it wasn't long, and we did find the next handful of patients. The second U.S. case and the third U.S. case came one after the other. One in Santa Clara County, one in Orange County, and then another later in L.A. County. It was our time to go to work. Leaving the airport screening in good hands with new CDC staff, a handful of us redeployed to rapidly contain any spread around the Orange County case. We mapped and traced, developed risk assignment algorithms, collected specimens, and mapped potential transmission networks. And I think we did well. No ongoing transmission from our case was identified, and I flew back home to Nebraska to begin working with the team here to begin preparing. It was undoubtedly coming here to Nebraska, and to me it felt like we were all just waiting for the dominoes to begin tipping. As more and more cases arrived in the U.S., all efforts and resources were spent on trying to contain every single case. But containment failed. It could not be contained like SARS-CoV-1 was contained. When we began realizing containment wouldn't be an option, we began talking about mitigation and NPIs. And perhaps we began talking about mitigation too late. I recall listening to Dr. Nancy Messonnier give a courageous and real, epidemiologically sound television briefing. It was the first time the message changed from low risk to American public, the line we had been using. She, for the first time, got the truth out, that COVID-19 could cause substantial disruptions to our everyday life. And she wasn't allowed back on telebriefings because of it. COVID-19 bloomed throughout the U.S. I wondered, as we were scrambling to set up traveler screening, might a national traveler health monitoring system help reduce transmission for novel introductions? I also wondered how the early days might have looked different if masking and distancing were already implemented as the virus was arriving. Might things have looked different? If we had a cohesive national digital case investigation and contact tracing system that could be rapidly expanded to meet pandemic needs, with testing readily available, might containment have been more effective? On March 11, 2020, the WHO declared COVID-19 a pandemic at 120,000 cases and 4,300 deaths worldwide. In a few short months, COVID-19 moved throughout the world, and we still knew so little about it. So what did we learn? We started learning about the incubation period. And remember, the incubation period is the time from exposure and symptom onset. The range for incubation period for SARS-CoV-2 is anywhere from 1 to 14 days. And the median incubation period is 4 to 5 days, which you can see on the graph on the right. That means that most people who are exposed will get sick 4 to 5 days later. The incubation period informs the quarantine period. Quarantine is for people who are exposed. It's staying away from others after exposure while you wait to see if you develop the illness. Quarantine guidance changed from a 14-day quarantine to a 10-day quarantine, and even shorter if you had a negative test collected after day 5 from exposure. And this is why. On the y-axis is post-quarantine transmission risk. On the x-axis is days after exposure. Although the maximum incubation period is 14 days, so few people get sick between 10 and 14 days. And that risk is just 4% if you end quarantine at day 7 with a negative test after day 5. So at this point in time, fewer and fewer people were following quarantine. So the thought was, if you can make quarantine easier, perhaps more people will do some of it. And perhaps that will prevent more transmission than everyone just giving up when they hear they'll have to be out for a full 14 days. Here, we began seeing the balance between science, a full 14-day incubation period, and the economic and societal costs of being away from family and work for 2 full weeks. This made sense to me, and it made me wonder, are there other ways to balance the science with the societal costs? What if we made some of these changes at the beginning? Might they have made things look different now? So we learned about the incubation period, but what about the infectious period? Who could produce new infections? And for how long could people be infectious for? Could you transmit the virus when you weren't even sick? We started seeing that asymptomatic infections could occur. But could those people still be infectious? We didn't know. We didn't know until we did. Nature published a landmark article that looked at cases and their contacts who tested positive, and they modeled that more than 40% of transmission events occurred prior to symptoms, before that person knew they were even ill. And this was huge. This meant that asymptomatic and pre-symptomatic people could spread COVID-19. As we learned about incubation periods and infectious periods, we also learned more and more about severity. We learned that unlike SARS-CoV-1, most infections were mild for SARS-CoV-2. And the combination of mild symptoms, which some might just think of as allergies or a common cold, and the fact that people could transmit infection before they even knew they were sick, that was the writing on the wall that this could not be contained and that it would spread everywhere. And at the end of the day, we learned most people who get COVID-19 are infectious for 10 days, and that infectiousness seemed to peak near symptom onset. We learned that people can be infectious even before symptom onset, and that individuals can be infectious for up to 2 days prior to symptom onset. And that infectious period is what informs the isolation period. So quarantine is what you do when you're exposed, which is based on the incubation period. Isolation is what you do when you're sick or test positive, which is based on the infectious period. These terms must be well communicated. All the timelines for quarantine versus isolation are confusing enough already without mixing these terms up. While most people are no longer infectious after 10 days, a very small number still are, which is why there's 3 main criteria that are used for when you end isolation. That's 10 days have passed since symptom onset, or from your positive test if you're asymptomatic. You're afebrile for 24 hours and other symptoms are improving. That's when you can end isolation. Outside of the basic epidemiology of the virus, we learned that airborne transmission does play a role, particularly in super spreading events. We frequently found super spreading events kick off increases in community transmission in different communities. A pattern was super spreading events among younger people that spread into pockets of vulnerable people more susceptible to severe outcomes like hospitalization and death. We saw COVID-19 spread in cities, take hold in more densely populated areas, and then it got into nursing facilities, meat processing facilities, and eventually out into rural areas. As we came off our big November wave, new information started hitting journals about mutations, specifically mutations in a variant of SARS-CoV-2 in the UK that made it even more transmissible, even more contagious. Through December, we learned more. The mutations did make it more contagious, and just like before, that virus made its way here. Soon, B.1.617, or Delta, emerged. This was more contagious than anything we'd yet seen. And Delta truly did change the game. It moved faster and more efficiently than Alpha. It outcompeted Alpha and other variants within a handful of months, and it produced a terrible surge even despite rising vaccination rates. It was able to find those who hadn't been vaccinated more quickly, and it filled up hospitals even faster and continues doing so. Several unknowns still remain. Long COVID-19 is still an unknown. How many people it will affect, for how long, and how badly is yet to be determined. How long natural immunity lasts, and how robust that immunity is, we've yet to hammer out. And finally, while Delta continues to burn, the side effects and after effects of the fire requires attention. I believe we will learn the true cost of the pandemic in years to come, and it won't be measured in COVID-19 deaths alone. So what did we do to battle COVID-19, and how is that battle going? It started with testing. Before COVID-19 even arrived in the US, we'd obtained the sequence from China and started working on a test. Where WHO succeeded, we failed. Even after we got the test to work, it was difficult deciding who to test and frequently left people confused and scared while awaiting results with a very long turnaround time. And while we were waiting for more tests, COVID-19 spread throughout the states. Why was the international community testing while we could not? Some of it might have been FDA regulation. Some of it might have been pride and the need to build it out ourselves. Both should be addressed to streamline future responses. Here in Nebraska, we did take advantage of our limited testing capacity as soon as we could. The Nebraska Public Health Lab was one of the first 3 public health labs to begin testing. The EPI team, local health departments, and I identified outbreaks and hotspots throughout the whole state. We partnered with the National Guard and set up test sites statewide that we moved from place to place to try to get testing where it was needed most, and needed most early on. And that specifically included communities with meat processing facilities like Lexington, Nebraska, which is pictured here, with cars wrapping around the building. Case investigations and contact tracing. These were other key interventions that we ran at this with. Through case investigations, we learned about associations between severe outcomes and different comorbidities, like obesity. We learned about loss of taste and loss of smell, and we learned how many people would end up in the hospital. Through contact tracing, we were able to notify close contacts of exposure and explain their quarantine period. We appropriately used the tools we had with all the information we had at the time. We learned that when you have a virus that can spread before you're ill, can spread rapidly, and can cause mild and asymptomatic infections, that the utility of contact tracing is more limited. When we began believing COVID-19 couldn't be contained, we shifted more attention to NPIs, non-pharmaceutical interventions. Distancing was the most straightforward. From social distancing to physical distancing, keeping people further from each other naturally reduced disease transmission. And for a disease that spreads primarily through droplets, 6 feet, or 2 meters was our starting point. Which brings us to probably the most important NPI, the mask NPI, which has a difficult history for us to entangle here in the US. When I was working at LAX or sitting in Orange County doing the case investigation, I recall wondering if I should be masked. At the time, we'd known SARS-CoV-1 was airborne, so I remember thinking masks probably won't do much anyway, and if the public begins buying up all the masks, we'll probably take all the N95s from the hospitals, which could actually protect from airborne transmission and which healthcare providers definitively needed more than the general public. We eventually learned that COVID-19, while it could be airborne, most transmission was still droplet, which masks could help against, and thus the recommendation changed. But not without substantial backlash, and I think the mistrust that change in recommendation produced is still hurting us to this day. Can we stockpile enough masks for the general public? Should we ever need to worry again about having enough? We certainly did then. The record was set straight on masks, but the issue became more and more polarized. Masking became a huge symbol of big government, a simple non-pharmaceutical public health intervention with huge potential for reducing disease burden, turned into a target for conspiracy and anti-government sentiment. But in lieu of vaccination, masking remained the primary tool at our disposal for getting back to normal as quickly as possible. Public health tried to communicate this. Lockdowns and closures, probably the broadest, most economically challenging, and difficult to sustain interventions overall. This is the heaviest hammer. The degree and duration of lockdowns and closures was and is very difficult. If we shut down, how long do we shut down for? Are we buying time to stamp out this outbreak overall, or just buying time? And if we're buying time, are we waiting to get more tests, to get hospitals more prepared, to get more ventilators? Buying time until vaccination? And how long could each of these things take? Is the lockdown for that long worth it in the long run? This is difficult to answer in the moment, but it's critical to analyze and understand moving forward. And when we lock down, will we enforce it? If we don't, is it just a recommendation? And will that work? One approach was, to put it eloquently, to cancel everything. Many countries and states did this. In Nebraska, we tried layered restrictions through directed health measures based on hospital capacity. But how much could we limit and restrict, and what power did we have to do any of this? The Supreme Court seemed to back up emergency power during a pandemic, so we could. But what worked? How would we know what closures might make the biggest impact and do the least long-term harm? Lockdowns did seem to correlate with reduced mobility. Overall, where states locked down, people traveled less than they did before. There were certainly exceptions, and some states that didn't lock down saw similar reductions in mobility. COVID-19 still reached everywhere. It peaked and declined everywhere, but the degree to which the lockdowns flattened the curve needs more dissection. It's possible and even likely they did buy valuable time, but unarguably, lockdowns and closures were heavy interventions that required an end date. I worry that in some situations, in implementing such strong interventions, we prompted leaders to rebound and put even more emphasis on reopening. If we're going to lock down, we're going to have to reopen, and if we reopen in all the reopening glory we can muster, we might see an even worse epidemic wave. And that's what happened. I wonder what might have been different if we put more emphasis on longer-term interventions like masking, creative dine-out options, de-densifying the workplace, and other more sustainable interventions. Indeed, we need to continue thinking about these as we enter another respiratory season. One way or another, what is locked down cannot remain locked down forever, and the success of future lockdowns might depend on more balanced transition and bridge from short-term intervention to long-term intervention, like vaccine. The COVID-19 vaccine story was a story of hope, of huge scientific achievement, and is an intervention we exceeded at. And it worked, and people hugged each other again, and we saw family again. And across the states, there was a sigh of relief. The vaccine is here. Science has won. We celebrated the science that got it here at a rapid pace that no other vaccine had been brought to market. And some of us called it. But then Delta arrived. Despite widespread availability, despite robust clinical trials and demonstrated safety and efficacy, some didn't want it, and many still don't want it. And so with Delta, the hospitals filled up again with a vaccine-preventable disease. And the cost to the economy and to our public health and healthcare workforces remain substantial. I think we're at a remarkable place in history, particularly in American history, where a medical public health intervention was studied, produced, and distributed at lightning speed and is being spurned by large segments of the population who continue to suffer. And some regret it. How do you convince those who are hesitant? What can you do to change people's hearts after 2 years of struggle? We've shown it's safe, that it works, and that it's needed to help our communities. At the moment, this is the biggest question I'm wrangling with. This is something we need to address as healthcare professionals, public health professionals, family members, and just as members of society. It's the most important question to address now and might be the most important to address for future epidemics. Let's talk about how COVID-19 has affected us. I recall hearing about the first deaths in China and the first doctor to die. I remember watching terrified as daily deaths increased and hearing that funeral homes had run out of coffins. When COVID-19 hit the nursing facilities, horror followed. And as it hit our population centers, there wasn't a mechanism for the standard system to accommodate all the death. And our numbers of daily deaths increased from 1,000 in total to 1,000 per day to 3,000 dead per day, and I still can't comprehend that much loss. At each terrible milestone, it felt like we lost. When anti-mask protesters filled town halls and anti-vax sentiment was broadcast on mainstream news channels, it felt like we failed. And deaths kept increasing. In addition to the life lost, livelihood was lost. It was the fear of COVID-19, it was the illness it produced, and it was our lockdowns and interventions that all contributed. COVID-19's impact on the economy hit hard, and it hit everywhere. It was measured in the stock markets, and it hit our daily lives. Our movies were canceled, casinos were closed, and even football was put on pause. It hit our schools, and it hit our hospitals and our healthcare and public health workforce harder than anything has in the past. Italy was the harbinger and served as a warning to the world, which we heard. The chaos, the triage, the impossible decisions that needed to be made, where people died who didn't need to. And I recalled the hospital I worked at through residency. I recall busy weeks on end through flu season, operating at above 100% capacity, and I remember questioning it at the time and was told if you didn't operate a hospital at 100% capacity, you lose money. We'd built a healthcare system optimized for profit and just-in-time care, and we were sorely unprepared for pandemic surges. It felt surreal when I first started seeing crisis standards of care papers being published. And whose role was it to support the hospitals? Was it the federal government or the states? And will we continue operating healthcare like a business? How quickly will we forget what this felt like? Will we grow from this or not? The predictions were correct. Hospitals filled up and overflowed. U.S. providers were forced to make the same decisions Italians had 2 months earlier. And the hospitals overflowed everywhere, even here in Nebraska. But you all stepped up to the plate. You did your job, and you did it together. And for all the valiant effort, for all the countless lives you saved, and good you did, we are still human. And while hospitals filled up again with a vaccine-preventable disease, it hurt, and it's still hurting. No one shouldered that burden more than you. No one fought that burden day in and day out like you. And healthcare providers and the public health workforce have a lot in common like that. The weight of the pandemic has not fallen on shoulders equally, and that's worth talking about. Did it need to be like that? Let's touch on leadership. Censorship was a factor I was naively surprised to find played a role even in a pandemic. The extent of that censorship continues to surprise me. I was truly astonished as a not dissimilar form of censorship began happening even among our response here in the US. It didn't happen to the same degree, but it happened nonetheless. Politics crept into the science. And more than censorship, misinformation spread like wildfire, some of which was propagated by our own leaders. And that misinformation only fueled existing anti-vaccine and anti-mask sentiment and resulted in more people landing in the hospital. The role of social media in communication of science and news was magnified, and through social media, misinformation spread rapidly through the world and cost lives. Efforts are underway to remove anti-vaccine misinformation. And I want to call out a delicate balance here, a balance between freedom of speech and censorship. The line between censorship of public health and censorship of misinformation might not always be clear. Censoring public health kills. Misinformation also kills. Whatever the answer is here, I hope it's able to control for different sensitivities of those in power. So what's next? In the end, COVID-19 completely washed over America and has grounded humankind. No one will be able to walk away from this saying with any haughty certainty, we had this, it was no problem. COVID-19 put us face to face with the increasing risk of pandemic zoonotic spillovers. It's an eye-opener to the increasingly present risk of pandemic disease. Perhaps now, finally, it is slowly getting less terrible. But when will it be over? I'm hopeful we'll soon be passing our final biggest surge. I'm hopeful that a combination of naturally acquired immunity and vaccine-induced immunity will prevent future surges and keep future respiratory seasons from looking like the past 2 years. But COVID-19 is here to stay. And when the risk of combined influenza and COVID-19 respiratory seasons meets a world that no longer cares to mask and doesn't care to get a shot, I'm simultaneously apprehensive that we must do more than just get past this. We must adapt. Coronavirus called our bluff, so what will it take to do better next time? I don't have all the answers, but it must start with talking about these questions. We must reflect and answer them together. We can't just let this pass by. So thanks all. Feel free to email me any questions. Appreciate your time, and thank you very much for having me. I want to just end with a plug for a special thanks to our public health and healthcare workforces. You guys are how we're making it through, and you all cannot be thanked enough. Take care.